Hello, everyone. We have an exciting webinar tonight. This is number 19 of our CCO case studies. What's going to be a little bit different about this particular case study is we're going to go over two main topics that are OB related. Actually, three topics that are OB related. We're going to discuss abstracting and how that plays a part in finding what you need to code. And we're going to talk a lot about some anatomy, because you know I love to do that, right? And then on the last case, we're actually going to talk more in depth about the coding, because that was the topic request that came in. But I thought, you know what, let's not just do one, let's throw some extra stuff in there as well. Plus, I like this subject, so that always helps. So we're going to go ahead and get started. If you have your manuals with you, I would pull out your ICD and your CPT. Have your little notebook with you too, so that if there's some terms that you're not familiar with, you can jot those down and go Google them later, or go to YouTube and get some more information about them. The topic itself, though, is unique cases that we find in obstetrical coding. Now, usually when we say OB, we say OBGYN, right? We are talking about obstetrics and gynecology, and the urinary system kind of plays a part in there as well. So, you know, some of the codes that we're going to look at may work in between OB as well as urinary. But just so you know, the theme that every one of these cases that we're going to talk about have in common is that they're unique, not something that's going to happen every day. So unique OB cases. Before we get started too, at the end of the handout, or at the end of your slide deck, there is a resource page, and where I got this information in these cases from, they were specifically from educational documentation that was provided for studies of well, one was emergency medicine, and then the other two were specifically about treating diabetes and some of the therapies that go with gestational diabetes and like type 1 diabetics being pregnant. That all being said, the first case that we're going to look at, didn't get a lot of graphics here, guys, a lot of black and white. So we're going to try to keep it interesting. And we're going to specifically talk about a diabetic condition that happens to people. We're going to learn about this MODY or MODY. I like to call it MODY, M-O-D-Y, maturity onset diabetes of the young. You may or may not have heard of that. It's not really type 1 diabetes. It's not really type 2 diabetes. And if you've heard of type 1.5 diabetes, it's not that either. It is MODY, M-O-D-Y, or they also refer to it as monogenic diabetes. And this isn't very common, but when it does happen, it happens with people that are a lot of times misdiagnosed. They could be stated that they're type 1 or type 2 diabetic. But the scenario that we're going to look at and practice abstracting content from is a report where we have a 19-year-old woman who is a MODY 3 diabetic and pregnant. Now, you're probably saying to yourself, well, wait, Alicia, tell me what MODY 3 means. Well, we're going to get to that. Not only is it a unique scenario because the mother is a MODY 3, the father is a MODY 2. Okay, so we have a mother and a father that are diabetic. And I'll explain here in a minute how this is a genetic disorder. So those little disease process spidey senses are going off in your head right now, right? So you have a mother that has a genetic disorder, and the father has the same genetic disorder. are at a different level. He's a MODY 2, she's a MODY 3. So what are we thinking, right? Chances are the baby is going to have some type of a diabetic condition if we know that this MODY is a genetic disorder. So that is exactly what this case study is about, is what happens when we have an inheritance scenario where you have the mother and the father. You know, what's the probability that treating her during her pregnancy, as well as taking care of the baby in utero, and the outcome of the baby when it's delivered. Now, real quick, we're going to look here. If you're not familiar with the way gestational weeks work and how you'll see them in documentation for OB coding, everything's done in weeks, but especially in high-risk pregnancies, but you know, they do it down to the day. So this particular mother, we have a 33-week plus 4-day gestation. That's what that 33 plus 4 means. Okay, so we're going to see that again and again. It's going to be exciting. Whitney already says, I've never heard of that. Well, then I need to explain what this maturity onset diabetes of the young actually is. Now, I already told you that it has to do with genetics, so that leads us to understand that it's inherited, right? It is a non-autoimmune type diabetes. Don't hear those two terms together often, do you? So the body fights itself ultimately. When you think of anything that says it's autoimmune or non-autoimmune, the body is in conflict. That's what I always think of when I see that. When this presents itself, they're going to find out in adolescence. So that's why a lot of times it's misdiagnosed as type 1 diabetes. And quite honestly, if the person doesn't go to an endocrinologist, if the doctor doesn't get a consult with an endocrinologist and pieces all of these signs and symptoms together, they may just assume it is type 1 diabetes and complicated type 1 diabetes. But genetic testing, if you go and have the genetic testing done, then it'll show itself. You can do more study on your own for that, and I encourage you to do so, because now that you know about it, you may see it more often. If it wasn't on your radar to begin with, then you know you might not ever see this again in situations that you're coding. So what is a clinical diagnosis? You know, what are the signs and symptoms, and what do we have to get a clinical diagnosis of MODY? Again, it's typically a person that's under 35, right? So adolescent or young adult. We don't think of 35 as a young adult, but typically when I did some research, a lot of these people are, it seems like it's, you know, 15 to 25, you know, a lot of the cases. So it'll be interesting what you find in your own research. They give the symptoms and the appearance of type 1 diabetes, which in the past we used to call type 1 diabetes juvenile diabetes. And the reason that is because it is a genetic type of diabetes. Your body does not function properly. Your pancreas, you're born that way. Whereas a type 2 diabetes is more of a late onset. It is true that your pancreas, you know, isn't participating with the rest of your body properly, but it isn't the fact that your pancreas is just wonky. That's my word of the day, wonky. So if you know about diabetes, you'll hear a lot of information about the pancreatic islets and the autoantibodies that are dealing with the pancreas. So ultimately, you don't have these pancreatic islet autobodies. Also, there's indications that there's indigenous insulin production, right? So they, when they say there's a honeymoon period, that when you first start with this diabetes, it really looks like type 1 diabetes, and then things start going wrong, right? And you're not classic. And so that's why they call it a honeymoon period. Or you could be doing really well, managing, and then things get crazy on you. They have another type of chemical that the body produces is C-peptide, and the presence of hyperglycemia, meaning your blood sugars run really, really high, as well as having the C-peptide. Low insulin requirements for treatment. Now, that's where things get interesting. We'll see that in this case study. A type 1 diabetic has to have insulin. The body does not produce enough insulin for it to control the sugars. So the sugar builds up in the body, and that's what the body has to have to feed itself energy. And if you don't have insulin to regulate the sugar, then the sugar builds up like a toxicity in the body. So the insulin is what helps the body burn that fuel, that sugar. And it's not, don't think of diabetes as the, more severe your diabetes, the more insulin you need. That's not really the way it works. Every diabetic is uniquely different. And what one requires in insulin versus another diabetic really is differentiated by the type of diabetes that they have, type 1 or type 2, because type 2 isn't someone that is required to have insulin, but they may use insulin. Their body mass, as well as their activity. The more active you are, the less insulin your body needs, because your body is going to burn off that energy. So if you have a marathon runner who's a type 1 diabetic, they're not going to use as much insulin as a person who is a type 1 diabetic and is a couch potato. Right? That makes sense, because the insulin is what burns off that energy produced by the sugar in the body. However, with a MODY diabetic, everything's going along and you have cases of hyperglycemia, but then what you would expect, the amount of insulin to be necessary isn't. You don't need that much. So you'll find cases sometimes in the beginning when they're trying to figure this out, where they'll, dose a certain amount of insulin, say 10 units of insulin in the morning, and they only need 2. That's not the way it would normally work. Okay, so low insulin requirements. And then another unique thing is that you don't have ketoacidosis when the insulin is taken away. Now, with a type 1 diabetic, if you take away the insulin, the person goes into ketoacidosis and you can die. But you omit the insulin and the body doesn't trip into ketoacidosis, which you would think, okay, well, that's more like a type 2 diabetic, but everything else indicates they're a type 1. So pretty interesting. Okay, that's the tip of the iceberg, really. Again, now that we know this little background about a MODY diabetic, you notice we said that the mother was a type 3 and the father was a type 2. There's like 13 subtypes of MODYs. So again, really to understand this particular type of diabetes, you're going to have to be followed by an endocrinologist, and most likely an endocrinologist that specializes in unique diabetes scenarios. Now throw on top of that the mother being pregnant, right? So we got a lot of specialties that we're working with. All right, so let's see, moving on. What are the atypical features that a type 2 diabetic would have? Well, onset of diabetes before age 45. Okay, so that's not going to happen. So even though it looks like they're for a while they're a type 1, but then you're saying, well, gosh, the insulin's not really working. We get high. We don't tip into ketoacidosis. We give them insulin and it's too much. And when we take away the insulin, again, the reaction's not normal. And this person gets what can have the signs and symptoms of type 2 diabetes, but they're much too young for that, because type 2 diabetics commonly are over 45. Lack of significant obesity, another classic case for type 2 diabetes. When you have somebody that says they're pre-diabetic, then that usually means that they're, obese. It's just, a sign and symptom that goes together. Lack of, acanthinosis to nigresins, and quite honestly, you can go look that up because I don't know much about that. It is not something that is talked about very often. Normal triglyceride levels, and this is interesting because high cholesterol, triglycerides and things are associated with people who are type 2 diabetics, which makes sense because obesity plays a part, and age, right? The older you get, then you have the possibility of having diabetes if you are obese. And if you're obese, you probably have cholesterol levels that are higher. So just kind of plays a part in the disease process. Fasting hyperglycemia that is mild. Wow, that doesn't happen. And don't really respond to the normal treatments, the medication treatments. Sensitive to sulfonylurea, let's see, hold on, I'm going to trip it up. I practice this because I just want to say sulfamides, and that's not the proper word. Sulfonylureas. Now, Barb's here. She'll give me a phonetic spelling here in a minute because she's good that way. Extra pancreatic features, meaning that you will have probably problems with your gastrointestinal tract, your liver, or your kidneys. Family history, that's huge. Family history is a huge part of what is going to be involved with this. So, like I said, it's an inherited trait. So if anybody else in the family has unusual diabetic issues, that could be a sign. Also, in contrast with type 1 or type 2, like I said, now how would that manifest itself? Well, if you have a type 1 diabetes runs in the family, but also you have type 2 running in the family, but they have not the classical symptoms like we just mentioned before. Okay. So that is a little bit more information about the MODY diabetics. Now, this particular information, I admit to copy and pasting from the research site about the different types. Remember, I told you there's like to date 13 types of subcategories. Well, there's 5 main types. Okay, and we know that our family involvement for our pregnant mama in this scenario is she's a type 3 and he's a type 2. So let's just talk a little bit about what 2 and 3, how they manifest out themselves, and then you can go and do more research, right? So let's talk about the father first. So if he's a type 2, it's mild. He can have not have many complications when they do fasting glycemic tests, and he has problems at birth with his sugar rate. Okay, there is some more genetic type discussion here, but he is generally asymptomatic, but he can have hyperglycemia at times. Okay, so you'd go in, you'd be checked, and you'd have high sugars. Okay, but you're just not really that classic type diabetic. And things that could trip you into having higher sugars would be pregnancy, doing family screenings if would be an indicator. You know, that may be the only way you found it, or other complications that, again, a type 2 is going to be less likely. I thought of myself this when I was reading this. I thought, you know what, they just might be a sickly person. You know, have the signs and symptoms of type 2 diabetes, but they never quite catch it or identify it, right? Then if we have the MODY 3, which the mother was. Well, that's a little bit different because they're going to have a classic diagnosis of diabetes, right? And they will probably classify them as a type 1, but insulin, you know, very low insulin levels are needed. And then let's see, then it tips to 5. I think I jumped to 5 because that was kind of interesting and I wanted you to know about that. But they have other complications that get involved with the body where they have multi-system problems. The kidneys are affected, and you have RCAD syndrome. If you're not familiar with RACD syndrome, go look that up. And I thought that was pretty interesting. So now we have our background, right? And we're going to pull it back to the information for the scenario that we have for our patient. We have a 19-year-old female. We're going to now practice abstracting what's pertinent. And the key here is in the beginning, they start her at 19 weeks. Okay, so that's usually you catch pregnancy earlier than that, but what's happening is she's going in for a consultation. That's because she's a MODY, and that's why this is a consultation at 19 weeks. So she's probably been following up with her regular OBGYN that was going to expect to deliver the baby. They knew she probably had endocrine, you know, issues, being diabetic, and decided, you know, once you get out of the first trimester and into the second trimester, then kind of a way to think about it is the pregnancy is going to take, right? Less likely to have a miscarriage. So now that she's at 19 weeks, they're going to send her to a consultation and make sure that everything's going to go smoothly for her pregnancy and for the baby. She has a specific type of MODY, and MODY 3 diabetes, but she has problems with her liver, hepatocyte nuclear factor. Right? You may not know what that is, so go do a little, write that down in your notebook, do a little research there. Oh, thanks, Barb. She told me I got that word right. Okay, so now we know what's happening. She is known to already be followed by a pediatric endocrinologist since age 11, right? So they knew she was a MODY 3, and she gets pregnant, and now they, you know, probably find it, well, the father is a MODY as well, and so you know, we're definitely going to have some complications. There is a strong family history of MODY, and they've been tested for type 1 diabetes but came back negative. So they also checked for gene mutation. Now, why are they doing all of this? Because it's a genetic, inheritable disorder, and they need to make a pathway to understanding her past so that they can plan the future for her, for the pregnancy and for the health of the baby. So it's not just one, even if it wasn't the father that was a diabetic as well, it would probably lead to complications. And so ultimately she's a case study. That's what this is all about. All right, moving on, and where you see the figure 1 and the table 1, just know that you can use the link that I provided at the resource page, and then you can actually look at the figure and the table, because it actually maps out the genetic family tree, which is really interesting. So the main words that should leap off the page when you're reading the case. Okay, so let's say this is all of the information that's done in a consultation, and you're needing to abstract that. You need to know that she's 19 weeks, that she's a MODY 3, that she's. It's also pertinent to know that she is followed by a pediatric endocrinologist. Now, usually with pediatrics, you are followed until you're 18, 19. And so, but you know that if they've been seeing this pediatric endocrinologist, she's going to have close ties, because it was since she was 11, right? Then also what should jump out for you is that some of the treatments that have been used. Excuse me, let me get a little sip here. Okay, so what are some of the treatments? Well, remember I told you that this sulfonylurea is significant, so they treated her with that, and she was switched to insulin here recently, and that's because she was having problems with high blood sugars. Okay, so she's pregnant, her blood sugars were reacting, and that would be, we already established earlier that when something happens to a MODY that's significant, like pregnancy, for example, then things will change in the body. And so she was getting by, obviously, without insulin, but now she can't. Her sugars are running too high. And when you have high blood sugar, you start having signs and symptoms, and you can go out and look at the signs and symptoms of diabetes, right? And this is not gestational diabetes, okay? So what's the plan? They're going to do bi-weekly growth scans. So they're going to check out the baby, right? Let's make sure that the baby is following standard growth levels. If you didn't know, mothers who get gestational diabetes, or mothers who are diabetic and are pregnant, their babies tend to be large, very plump, very roly-poly babies, but you're looking at 8, 9, 10-pound babies when they deliver. So it's very important to follow the bi-weekly growth scans and make sure that this baby is on track with what they should expect. They started these at 24 weeks. So she came in at 19 weeks, had her consultation, okay? And now you have the endocrinologist working along with the probably a high-risk pregnancy OBGYN. So they're checking the baby and at 24 weeks. Now, think about what you know about premature viability. And we know that babies have been able to survive at 24 weeks. So they're going to, again, really follow both the mama and the baby to make sure we don't have complications. They set targets of what they want. So they're going to manage her glucose, her intake, her diet, her exercise, and the insulin. Well, look what happens here. She is on Lantus and Nova Rapid with meals. And if you're not familiar with how insulin treatment works, you're seldom on one insulin. And Lantus is one type of insulin, Humalin's another type of insulin. There is several type of insulins now. We have natural insulins, synthetic insulins, they have extended release insulins. You know, there's again, it's a really fascinating study. So if that is something that you think, oh, I want to learn more about that, absolutely go look into that. We have also done in our pharmacology course, it's going to be launching soon, an in-depth study in endocrinology and pharmacology and how that works together. So you may want to jump into that if this, again, is something that interests you. So noticed here where it says that insulin requirements gently increased over the pregnancy. That's kind of what they would expect to happen. Okay. So but they said gently, not specific, we're not going from getting, 3 units to 5 units to 10 units. Okay. That's what you usually think of. But this is 0.75 units, tiny little amount of insulin to 0.83 units at 28 weeks. I mean, this is really detailed amounts of insulin. And if you are not familiar with gestational weeks, you can go out and do, it behooves you, you need to be familiar with that. If you haven't tested yet for your credential, you need to be familiar with first, second, and third trimesters and the gestational weeks that are involved in those. Don't worry, it's all in your ICD manual, at least good manuals they are. But and you don't have to have it memorized. You just need to be aware of what you're looking for. All right, moving on. What happens? Now we're getting into 28 weeks. We deliver usually at 40 weeks. That's the prime gestational week. So from 18 weeks to 28 weeks, we increased a little bit of the insulin. After 28 weeks, what should jump out at you is emergency department. Okay, so they ended up reducing her dose because she didn't need as much. So they were gently increasing it, and then they start decreasing it. And then boom, at 33 weeks and 3 days, she ends up in the ER with hypoglycemia. So her blood sugar drops so low that she, probably can't function properly. You get lethargic, you get sleepy, you can look like you're drunk, quite honestly. So they admit her, and they need to do some studies. They need to check the baby, and they need to figure out what's her insulin level that they need to put her on. So again, she'd slowly been increasing, and then all of a sudden they had to drop it because she was it was too much, and she's already getting barely a unit, but she does need it, right? What do we know that we've already discussed about a MODY, right? Nothing typical here. What we would think would work, the body reacts, isn't reacting properly, so, and that's because she's a MODY. So they get her down to 0.28 units. I mean, I feel like that's just a drop. What happens was she got a significant fall in insulin requirements. That's going to be a problem possibly for the baby. So they want to start checking her for hypertension. They also want to make sure she doesn't get preeclampsia, which is what happens ultimately when your body goes into severe hypertension or extreme hypertension when you're pregnant. If you aren't familiar with preeclampsia, you need to study that, okay? So write that down. They checked her several times, but she's always within the normal limits, so that's great, okay? But hypertension is something that they're very worried about. because this particular type of diabetes affects other body systems. And when you're pregnant, it tends to affect hypertension. So now let's look and see what else they're going to start following. After she goes to the ER, and mind you, this study was actually came out of Australia. So that's why it's the this ASUM growth chart is out of Australian Society of Ultrasound and Medicine. That was kind of cool. You can find these type of studies out on the internet if you know where to look. But if there's a particular area that you're interested in, say diabetes and unique scenarios with diabetes, it's classic, right? To find some interesting stuff. I do it all the time. So we're measuring the baby now. We want the baby to grow, but we know that a diabetic baby is going to be nice and plump. So we was like, what's happening with this baby? They do bi-weekly monitoring now of the baby via Doppler, and they're doing measurements, which if you've ever been pregnant, you know, they go from the pubic bone up to the top, or kind of above where your belly button is. And that's significant. They'll measure you every time you, once you get into your second trimester, they start measuring you like that. Because they're concerned about the baby and the possibility that this baby is going to need to come early, they go ahead and start dosing her with a medication that's going to help develop the baby's lungs quickly. It's there's several medications that they use. This particular one they're using is betamethasone, and but you'll see others. And again, you have to remember this is coming from Australia, so you know sometimes the terminology for medications, the verbiage may be a little bit different if you're not familiar with that. But again, it ultimately is like a type of steroid that helps develop the baby's lungs. And so they start giving her that. She ends up with 2 doses of that just in case the baby's delivered early, the lungs will be mature. They're speeding up the process. Now they get her to 34 weeks plus 3 days. Okay, so that abstract, that should leap off the page. Every time you see gestation, that is going to be pertinent to what you're going to code. The other thing when you're coding for OB is, did they go into labor? If they did they go in early? How many weeks gestation were they? Was it spontaneous or were they induced? Okay, so this is spontaneous labor. So she went into labor on her own at 34 weeks plus 3 days. So she's not even at the halfway mark to 35 weeks. Now there's a magic window for premature babies. It's almost like, and it's really weird, you can study it yourself. Sometimes babies do better when they deliver pre-32 weeks versus after 32 weeks. Between 32 weeks and 38 weeks, I think, babies tend to not do as well. And I think girls do better than boys. You know, don't quote me on that exactly, but the scenario is out there. So study a little bit about that. Go and do some research. We do know, okay, 34 weeks and 3 days, spontaneous labor, and she delivered. Okay, now the fact that she delivered is not, they didn't stop the labor, because they can do that. We have labor and delivery, okay, from this point on. So when you go to code that, you would also want to be aware that they used forceps, because there are particular types of codes that go along with that. Also, if you're not familiar with the APGAR scores, a perfect score is at 10. I had a OBG YN that told me that he never gave a baby a 10 because no babies are perfect when they're born. The fact is if their APGAR scores are lower and you want to see them go up. So that's why you see we have a 7, 9, and 10. A lot of the times I noticed in the documentation, very seldom do they give you a 10, but they may give you a 9, right? Because the babies just don't come out perfect. And there's a criteria for APGARs, and you can go study that as well. So came out of 7 at, and this is the way they time it, at 1, 5, and 10 minutes, right? So at 1 minute, right after that baby came out, the doctor did the APGAR scores and they were a 7. And then they repeated the APGAR scoring at 5 minutes and they were a 9. And by 10 minutes, boom, perfectly healthy baby girl, it says. So now that we know that, we've delivered, we are premature, right? 34 weeks plus 3 days. They examine the placenta, or they usually do, but it says that they didn't, okay? And again, I don't know how they do things in Australia. Due to the baby being premature, though, they take the baby to the intensive care unit. The fact that the baby's a 10, excellent. That's great. And the baby was discharged at 36 weeks and 1 day. That's impressive too. You know, so the baby did spend a couple weeks, and another thing that we think about, not just with prematurity, but when you have a mama that's a diabetic, whether it be regular diabetes or gestational diabetes, that baby is getting, has that excess sugar in their system. That's why you've got little plump babies. And the mother's body isn't able to compensate for that. So when the baby delivers, they're used to having that high level of sugar in their system, and all of a sudden they don't have it. So sometimes gestational diabetic or diabetic mothers, the babies will stay in the hospital a little bit longer than someone, if the mother wasn't. Now, not always, but you know, there's usually a day or 2 extra at least because the baby's trying to regulate their blood sugars. Add that to the fact that we have a premature baby. 2 weeks is really, really good, right? So this is a nice, healthy baby. Now, they're going to immediately start testing also the baby because the mother and the father both have genetic disorder, endocrinologistic, that's a word I just made up, disorders that are known to be inheritable. So they're going to immediately start testing the baby for this gene to see if they have it. And it's the HNF1A gene. There's a table in the notes, again, that you can go reference and look more into that. And guess what? The baby does not have the gene and is maintaining sugars well. Everything looks to be okay. So because this testing was all done ahead of time, that leads them to believe in the study that the baby is not going to have any ill effects from or has not inherited these attributes from the mother and father. So may never have a diabetic issue or endocrine issue due to this particular genetic variant. So that's kind of exciting. All right. Now we're going to wrap up this particular scenario. So again, this has been mostly about abstracting what we need to know when we have a unique scenario like this, what we need to go back and study if we don't know, and understand the disease process. That's what makes you a better coder, is understanding the disease process. And in turn, if you understand the disease process, then it makes sense, the CPT codes or the PCS codes that you'd be using for the procedures and tests that will be done for the baby. What should leap off the page in the conclusion is that we're going to have documentation for multidisciplinary specialists. We have an obstetrician, we have endocrinologist, and I'm sure that we didn't just have an endocrinologist, but we also had, in addition, a pediatric endocrinologist, because the mother had been followed since the age 11 with this genetic disorder. So the pediatric endocrinologist would be giving information in turn with the regular endocrinologist that she probably started going to after she turned 18. A geneticist would be involved because, as we said several times, this is an inherited, unique type of diabetes that has a gene variant, and it's inheritable. And you have a mother and a father that are MODIs. So again, very unique situation. You're going to have geneticists involved for the baby when the baby's delivered, as well as getting information and probably doing testing for the mother and the father so that they can, kind of try to predict what could happen to the baby. And of course, a pediatrician. And not just any pediatrician, probably that the pediatrician right after the baby was born, and then the pediatric endocrinologist would be involved until they ruled out that the baby has, none of the attributes of the parents, right? So again, we got a lot of disciplines going on. That means a lot of consultations, a lot of tests that you would be reading and trying to abstract from, and as well as procedures, ongoing lab tests, and you probably have not read documentation from a geneticist. So, that will be a unique type of documentation. All right. Both parents were affected. We do know that. So that is, again, very evident, something that you're going to have documentation coming in from the father in the mother's chart, right? And then you're going to have documentation that was given from the mother and the father for the baby's chart for family history. It was, though, pertinent that both the mother and the father had MODI, but they had different mutations. One was a 3 and one was a 2. That makes it unique. You would think, well, what's the big deal there? Well, if both were 3s, it would be fine. Or it wouldn't be fine, but it would, what I'm trying to say is they could predict, right? But what makes this unique is you have 2 different, you have a 2 and a 3. What's that going to do, right? And then also it says they are going to follow the extent the fetus is affected. So all of these charts are going to be mingled in on top of each other. And especially for new coders, when doing OB work and abstracting, it gets very difficult because it gets convoluted. Everything about the mother stays in the mother's chart, okay? And the baby, considered a fetus, is also coded, everything for the baby is also in the mother's chart until delivery. And then they become 2 separate charts. Okay, and like I said before, then all of the attributes of the baby are not going to be put in the mother's chart anymore. The baby has their own chart, but the baby's chart is now going to have family history and copies of consultations and everything from the pregnancy in the baby's chart. Okay, and then we throw in the father as well. That will be in the mother's chart and the baby's chart as history, family history. So flipping through all of that can be difficult. And whenever it says extent to fetus is affected, that should be a red flag that, oh, we've got something going on. What was significant, again, with MODI was that usually more insulin's needed, and she needed insulin taken back. right? But that was a part of her condition. And then the last couple things is that, you know, they were not sure how being a gestational diabetes, how type 1 and type 2 diabetes, the available data and information that they collect a lot through coding, by the way, because we do these statistical captures. It's not the same with a MODY patient. Okay, so everything that they know about gestational diabetes, that, you know, which is a mother that's pregnant that turns into a diabetic, and once the baby's born, they're no longer diabetic, or a mother that's a type 1 or a type 2 diabetic and gets pregnant. That is completely different than what happens to a MODY mother that's pregnant. Okay. So again, very, very fascinating. And that kind of wraps up everything that should leap off of the page when you have a unique scenario like this MODY diabetic. The next subject is uterine prolapse. So let's talk about uterine prolapse and what it is. We're doing good with time. First of all, uterine prolapse is pretty rare. It doesn't happen that often with pregnancies, but if it does, it becomes high risk. Okay. The statistics here show 1 in 10,000 to 15,000 pregnancies do they involve uterine prolapse. So what actually is uterine prolapse? It is when the uterus falls down into the vaginal vault and starts to come outside the body. And there's several stages of uterine prolapse. There's treatments that can happen, but when you have a pregnancy involved, that's going to be a different type of treatment than you would if you had uterine prolapse in a woman that is usually older, is what happens. So it is it's common, and for older women not pregnant. Okay, so make that clear that when you get older, the muscles and the walls of the uterus supporting the uterus weaken for lots of different reasons, and then the uterus can just slip down. You know, the cervix and the uterus just slip down into the vagina, and then could slip down just a little bit, or could actually start to come out of the body. Now, it won't detach itself because it's attached, but again, it's almost like a hernia. Think of it like a hernia. So there's treatments that have been used for a long time, and they're very effective for older women that have uterine prolapse. But if you have uterine prolapse complicating a pregnancy, that's very different. Okay, and again, unique. So the key words here is that with uterine prolapse, is it an older woman or is it a pregnant woman? If it's a pregnant woman, this is now a complication. And we all know that whenever you see that magic word, complication, that changes the way we code something. This is going to be complicating pregnancy. It's not a complication due to a procedure, because there's codes for that. This is something that is going to follow the pregnant mother all the way through to the delivery of the baby, and is probably going to need follow-up treatment afterwards. It doesn't always resolve itself. There may need to be surgery. A lot of research that you can do in uterine prolapse, but again, make sure that when you're looking at it, are you looking at it for the management for an older woman that's more common, or for pregnancy, and the treatments will change. Ultimately, if you do have uterine prolapse with a pregnancy, there can be lots of things that can cause this. Again, it's rare, but there's several things that it could be one thing that caused it, but it's usually a combination of several things because it just doesn't happen that often. There's a list. I went ahead and made that. I put that in italics because I wanted you to be able to just read that. I'm not going to go through all of those because if there's anything there that you don't understand, you need to go out and do the research for that, right? But again, it's usually not just one thing. It's usually several things that end up happening. More common is to have uterovaginal prolapse. If you look at characteristics, white and Hispanic women have it happen more often than African and Asian descent women. So I thought that was pretty interesting. I wanted to make sure that was there. How do we know that? Because of the statistics that we collect, in part through coding. Right? Now, we don't code whether a person's Hispanic or Asian or white, Caucasian. We don't do that. However, it does get tracked, right? Because it's in all of that. You fill that out every time you go in, right? And it's important because we do know certain disease processes, diseases, and etiologies and stuff are prevalent for different types of nationalities. So this is what uterine prolapse looks like and the stages. So if it's a 0, it's just barely, it's just barely starting to slip down. The cervix has slipped and the uterus is coming down a little bit. This is going to be really uncomfortable, to say the least. But noticed here, and I thought this was a great graphic because you've got the 0, 1, 2, 3, 4, and then it literally is how far it slips down into the vaginal vault. So if you've got a stage 1, again, it's coming through a lot more, and it slowly increases until it is exposed to the outside of the body. And that's going to happen in stage 2. Okay, so that from stage 2, you're going to be able to see the cervix there at the opening, and then vaginal opening. And then 3, you're actually seeing, part of the uterus coming through. Now, there's lots of pictures out there. I chose not to grab those, and you can do a Google image search of uterine prolapse. We're very careful about taking graphics that you can go grab off of Google imaging and getting permission to use those, right? And this is something that, again, to see it in real life compared to an image, again, is a little bit different. But this happens a lot with cows. So if you go and you Google image, when the calf is born, the uterus just inverts itself sometimes. So that you may see some things and you think, oh my word, what is that? But it's because it's a cow, not a human. Okay, let's talk about the first case. Now we are going to, again, in this case, not necessarily talk about all of the codes. We will, but we're going to get a little more in depth on what we need to abstract, just like we did before. So the first scenario that we did was about something completely unique you've probably never heard of. Now, most everybody has heard of uterine prolapse. You may or may not have to code it, but you don't code it necessarily the way you think you do. So we will talk about that. So we're going to do some abstracting and a little bit of coding. So we have a 27-year-old Chinese woman. Why is it pertinent to know that? Well, age, okay, Chinese, but didn't you see that last comment on the last slide was that it's not as common in Asian descent, okay? But this case scenario, we actually have a woman of Asian descent. If she is Gravata 3 para 2, what does that tell us? If you don't know, you need to research that, because this you do need to know. That means she's been pregnant 3 times and she's had 2 babies. Okay, body mass index, not necessarily something that's important unless she's obese. Okay, if you have a body mass index of, you know, what is it, like 42 or something like that, it risk adjusts, but she's got a very low body mass index. And in fact, if it's below 15, that's pertinent. You know, we're getting into malnutrition, but most women of Asian descent are more petite anyway. She went to the clinic at 8 weeks and was noted to have a prolapsed uterus at that time. Okay, so she is only 8 weeks pregnant, probably just found out she was pregnant, and I would suspect, and again, I'm making an assumption here, but she probably was having was uncomfortable, having pain, went in, found out she was pregnant, and found out that her uterus was prolapsed at that time. So it revealed that she was a stage 3. Now, we looked at the stages. Stage 3 is significant. That means it's exposed, right? The uterus has already started to be exposed to the outside of the body, and it's not meant to be. That type of tissue is meant to be inside the body, not outside. So you have to deal with infections and ulcerations and all kinds of stuff like that. So we have a stage 3 uterine prolapse, and notice now all of this information, okay, that looks like algebra or some type of chemistry equation. We're going to talk about this. If we say that they are a POPQ, that's pelvic organ prolapse, okay, so a POP is pelvic organ prolapse. You can have other organs in the pelvis that prolapse, your bladder. But there is a kind of a grid or a table that gives us quantification to explain it. Now, I'm not going to read all this up because you can see it, and don't need to put it in the transcript that we're going to be working with. But I'm going to show you what these mean. So the main thing we know now is that she's been pregnant three times. She's had 2 babies. She has a stage 3 uterine prolapse, and she is 8 weeks pregnant. Okay. They on the examination, they say that her uterus could be restored to the pelvic cavity within bed rest. So they literally are going to push the uterus back up into place, and if she lays flat, it stays. It doesn't pop back out, is ultimately what they're saying. It was more serious though if she got up, she stood up, or started walking around. They wanted her to be hospitalized, but she said no, and she went to continue her pregnancy at home. Now, keep in mind all of these letters and numbers, and we'll talk about those in a minute. Right there. Notice the AA, the BA, GH. This is what they mean. So we're quantifying a better description of the uterine prolapse. And the fact that she's a stage 3, we know how far it's prolapsed, but is it the anterior wall? Is it the cervix or the cuff of the cervix? Is it posterior wall? Is it total vaginal length, involved? So all of this gives you an in-depth description. Excuse me. And this description is the same whether the mother is pregnant or not. So now that you know what all of those descriptions are, when you saw that it said AA +3, that means that it was the anterior wall. It came down to the anterior wall to a +3. Then the C might be a like +2, and the posterior wall may be a +2. 2 also, or a 1. What does this say for you as a coder? This does make a difference in the way that you code it, but not to this specificity, okay? You just need to be